Hello and welcome. I'm your moderator, Faith Rogers with DKB Med. You are in for a great presentation today with expert faculty who will do their best to make sense of what we know about preventing COVID-19. So for those of you who may be joining us for the first time, welcome. And if you've participated in some of our over 170 webcasts on this program, we definitely do welcome you back as well. We've been developing COVID education since March of 2020, so over 2 years later, we're definitely incredibly grateful to all of the progress that we've made managing patients during this pandemic. So, okay, here are those great faculty I mentioned earlier. So for those of you who have been with us since last year, you will likely recognize both of them. But for our new learners, please do meet Dr. Auwaerter and Dr. Angarone. Thank you both of you for taking time out of your busy practices to be here today.
Yeah, happy to be here. Thanks for having me. Welcome, everyone.
Yeah, thanks, Faith, and welcome.
All right, well, here are our faculty's disclosures. This educational activity is supported by an independent educational grant from Gilead Sciences Incorporated. All activity content and materials have been developed solely by the planning committee members and the faculty presenters. As a note, this program has information that is up to date as of April 26th of 2022. So if you're watching this on demand on another day, definitely do advise you to check out the NIH and IDSA guidelines for the most contemporary information on their recommendations. So the learning objectives today are to assess the impact of COVID-19 on vulnerable populations, including those from racial or ethnic minorities and those with comorbidities, and also to evaluate best practices for treating ambulatory patients with COVID-19. I will hand this over to Dr. Auwaerter. Dr. Auwaerter, thank you so much.
Yeah, thanks so much, Faith. And my portion of the program will be dedicated to giving some current insights into where we are and also some of the prevention strategies, of course, but we won't be focusing on vaccines. I think so many of us hope that COVID-19 and the virus are far in our rearview mirror, and there have been dropping of mask mandates in many parts of the country. Uh, Public transit, for example, airplanes and airports, although local regulation may still be in effect. But since the fall, Omicron has been a variant that has been increasingly prone to transmission. And as an RNA virus, SARS-CoV-2 inherently has less fidelity than DNA viruses, so more mutations. And there's still millions of mutations, not only in North America, but worldwide. So the chances for new mutations to develop are certainly opportune, which is why I do not believe the WHO will end the pandemic until case numbers have remained substantially low. And certainly with China on the cusp of issues, I think this is not likely. Now, looking at the United States, what we can say is that the Omicron surge over December and January was so rapid up and down that the number of reported infections vastly underestimate actual infections. It may be 2 to 3-fold more based on people that did home testing and was unreported or people that were undiagnosed. But importantly, if you look at the number of infections, proportionately, the number of hospitalizations and deaths were far lower than the earlier peaks that you may have seen with the Alpha variant and Delta variant earlier surges. So more recently, despite the numbers becoming quite low, especially in early April, they are beginning to rise again. And in part, that's because the Omicron variant has had subvariants develop that are increasingly transmissible. And the Centers for Disease Control has been performing genomic surveillance and incorporating results from sentinel centers across the country. And what's happened is that the orange Delta variant was quickly replaced in December by the Omicron variant, which was the lighter purple by a dark purple. And then very quickly, the BA2 subvariant of Omicron has established itself. But wait, there's even a subvariant of the subvariant of BA2, which is now increasing quite a bit. And for example, in New York State, now represents over 80% of identified infections that are sequenced, and even higher in central New York. And that's only a very limited perspective. So, again, given the extent of infections, more mutations will occur. So, I think there may yet be surprises in store for us. And certainly with the dropping of mask mandates and people generally being less cautious, there'll likely be some increased numbers of infections. And that's been seen in the United Kingdom, Denmark, other countries where BA2 has been so common, but we haven't seen the commensurate increase in infections causing hospitalization. So the pathogenicity has remained relatively less. People that are being admitted, though, are those that remain with risk factors, especially immune suppression or people that are unimmunized. Now, risk factors for severe illness 2 years in, I think the lists have changed a bit over time based on levels of evidence. I think you're probably familiar with most conditions on this list. A few that I would probably point out that might be relevant for the second part of this talk with Dr. Angarone. But importantly, pregnancy remains a severe possibility for illness, especially in the third trimester. And of course, immunization is encouraged. Immunodeficiencies and solid organ transplant seem particularly prone. Potentially. But there's maybe less evidence for the far right column there. But basically, the other risk factor, of course, is age, and the age gradient is rather steep and does climb certainly as people head into their 50s, but gets very high by in the 70s and 80s. And in fact, a substantial number of deaths are in the advanced elderly. One other factor that's not technically medical, but may reflect more social factors and economic factors and access to care is that certain racial and ethnic groups are much more prone, at least throughout the whole pandemic, to land in the hospital or unfortunately succumb compared to non Hispanic people and Asian people as well. So something to keep in mind, and why often trying to facilitate care to those groups has been a priority in many cities. As I've mentioned, immunization remains our best approach, hands down, for preventing serious illness. And what's changed is that early 95% stance that the infection first seemed to respond to the promise of the vaccine back in December of 20 has been blunted a bit, especially by Omicron. So the vaccine efficacy is not as strong, but still a very effective vaccine. And I hope to show you why. Many of you have probably had trouble keeping up with vaccine recommendations. We still do not have it for children under 5, and that data probably is forthcoming shortly. And I expect probably children under 5 will be able to get vaccine this summer. But the couple things I would point out is because of heart inflammation, myocarditis, which seems particularly prone to adolescents and younger adults, especially men and boys, is very much alleviated by spacing out the primary series. Instead of doing the second dose 3 to 4 weeks apart, extending it up to 8 if people don't have severe risk factors really reduces that risk of myocardial inflammation. So that's one item I've recommended. Another key point that I think will happen over time is really after primary series, the booster is incredibly important, especially for Omicron, to help not only rise waning antibody titers, but to better handle the virus that since has evolved. And really, I would say the primary series really should be thought of as requiring 3 doses of vaccine, although that's not the way it's currently characterized. That's how I like to explain it to patients. You need to get 3 doses. Now, there is a second booster, of course. And that's only really recommended for people with risk factors who are adolescents with Pfizer, and for Moderna over 18, and anyone over 50, basically, or have risk factors such as immunosuppression can also get that second booster, which is better characterized on this slide here. And the immunocompromised program really essentially gives people an extra dose. So it's your normal schedule with the potential of 2 boosters, except here, indeed, the primary series is 3 doses. And one could argue it should be 4 doses for primary series, and then you need 1 booster. But be that as it may, this is the schedule for that group. And even then, certain patients, especially those with B cell disorders or taking medications such as rituximab, are especially prone. Now, unfortunately, that initial booster is not being used as much as it ought to be. And while many in the United States are liable for a booster, and of course, Asian and white populations tend to be older than people of Hispanic background and Black. But unfortunately, what's happening in the United States is that while we're a little over 2/3 of people receiving the primary series, the people who have gotten at least the first booster dose is only at 30%, and the second booster is less. And of course, there's controversy about the efficacy of the second boosters being truly necessary for many people. But I think this is being done in anticipation that there could be further mutations and enhanced immune responses may be helpful. That second booster may wish to wonder about the timing and if there's a lot of virus in your community where it might benefit you. However, and we could talk more about that in the Q&A, but one of the areas of the country that I like to show, and it's mainly because the public health officials in King County have done a very good job of collecting health data and immunization records and marrying them, is to give you a sense of how effective in real time immunization is. And this just shows you data which has been toggled only to the Omicron variant. And so that's really since December 1st onwards. And although the vaccine efficacy of people that are boosted is better than those that only get 2 doses, it where you really see a difference is in hospitalizations and deaths, where if you're boosted, your chances of developing severe illness are far less than certainly someone that's unimmunized. And also significantly, maybe almost tenfold less chance of dying than if you didn't get a booster, but were only getting the initial series. I'll finish by saying that for those that do have profound defects in their ability to respond to vaccine, the drug here, tixagevimab, silagevimab, which has been available again since for months now, is now more available. There was some difficulty getting sites up and administering this, but this combination monoclonal antibody has had modified FC receptor and has a very long half-life, such that there's only 2 doses required. 2 doses per year or once every 6 months to help offer protection. And this dose was increased in February. So those that might have gotten the initial 150 dosing need a 150 catch up. So this is approved for anyone over 12 and older, again, with those inabilities to respond to vaccine, or perhaps they're contraindicated to get the vaccine. Unfortunately, it's slow onset because of the way the drug is distributed from the muscle into tissues, means that it's not very effective for the first 2 weeks after administration. So it's not for post-exposure prophylaxis. And the reason this still works is now that the subvariant BA2 is still highly prevalent, that the combination, which you see by the trade name in the first row, when you break down the components, and in the red box is silgivimab, which is fairly effective on its own compared to tixagivimab just below it, where it has much more mixed data on impact. So this is something that I think might be increasingly relevant for immunosuppressed patients. So now I'm going to hand it over to Michael, who will take you through some treatments that could be considered for your patients. Michael?
All right. Thank you, Paul. Thanks for that overview of the kind of where we're at with SARS-CoV-2, but then I think also some of the changes in the information that we've discovered over the past 2 years. I'm going to focus on the outpatient treatments for SARS-CoV-2, and this has really expanded, I think, especially over the past year. I'll start kind of reflecting on what Paul talked about with the tixagivimab, silgavimab, which is kind of the change in the monoclonal antibodies that we've seen over time. And this table just kind of demonstrates the different monoclonals that we've had. We've had the bamlanivimab, adasivimab, casirivimab, imdivimab, sotrovimab, the tixagivimab, silgavimab, and now the Beptilovum. And we can see that for a lot of the early variants of SARS-CoV-2, these antibodies were very effective. But as we went into beta, gamma, and then especially Omicron, we've actually seen decreased activity of these antibodies. And during the Omicron surge, the sotrovimab, especially with the B.1.1 variant, was still very effective. The Beptilovum was just kind of coming on the scene around that time. But now we're in the era of the BA2 subvariant of Omicron, and there's been reduction in the activity of the sotrovimab, which has really had our focus with the monoclonals on the Beptilovum antibody. And this is reflected again in this dashboard that Paul showed you for the silgavimab, tixagivimab, where we can see kind of the wide range of activity for many of these monoclonal antibodies, but the Beptilovum really maintaining its activity against the BA2 variant of Omicron. And so as we look at the different therapies for the outpatient, I think starting with what are the current recommendations, and then we'll talk about each one of these therapies. This is the most up-to-date NIH recommendations for non-hospitalized individuals with mild to moderate COVID-19 that are at high risk for progression to more severe disease. The primary recommendations are treatment with 2 direct-acting antivirals, so either nirmatrelvir, ritonavir, that's given twice daily for 5 days, that's initiated as soon as possible and within 5 days of symptom onset for individuals that are 12 years and over and 40 kilograms and over, or Remdesivir, which is an IV infusion that's given once daily for 3 days, again, starting as soon as possible and within 7 days of symptom onset. And it is recommended for those that are 12 years and older and 40 kilograms and older as well. There have been some changes with Remdesivir's recommendations in the broader scope with the FDA that I'll talk about in a bit, because it's now recommended for essentially all ages of children, so those that are 28 days and older, which we'll talk about in a bit. If an individual cannot take or does not have access to either of those 2 medications, the NIH does recommend either the monoclonal antibody Beptilovum that is a one-time infusion again, given within 7 days of symptom onset for those that are 12 and over or 40 kilograms and over, or Molnupiravir, an oral medication that's taken twice daily for 5 days, again, given within 5 days of symptom onset. This one's recommended for those that are 18 and over, so not for younger individuals. I think another important recommendation by the NIH is that dexamethasone or steroids are not to be used for these individuals that have mild to moderate COVID-19 unless it's being used for another indication. So they're not indicated to treat outpatients with COVID. So let's go into a little bit of the evidence for these therapies. So we'll start with the oral therapy, Normotelravir, ritonavir. This received EUA from the FDA in December 2021. This is an oral direct-acting antiviral that is a protease inhibitor, and it's paired with ritonavir, which is a potent inhibitor of the CYP3A enzyme system, which allows the medication to stay in the circulation and not get metabolized as readily. The data for this therapy comes from the EPIC-HR trial. There was interim analysis that was reported around the time of the EUA, and we now have the final analysis of the data of around 2,200 adults with at least one risk factor for severe disease. These individuals were randomized within 5 days of symptom onset, and the study looked at hospitalization or death, and they actually looked at those that were given the therapy within 3 days of symptom onset and those within 5 days of symptom onset. Those that received therapy within 3 days of symptom onset, there was an 89% reduction in the hospitalization or death, so 0.7% for the Normotelravir ritonavir versus 6.5% in the placebo. No deaths in the treatment arm and 9 in the placebo arm. When looking at treatment that was given within 5 days of symptom onset, the hospitalization or death was reduced by 88%. It was 0.8% in the treatment arm and 6.3% in the placebo arm, and no deaths in the treatment and 12 in the placebo. This study also looked at individuals that were 65 years and older, so kind of getting to that age cut point where we start thinking about the higher risk for progression of disease. And again, the treatment arm, there was a 1.1% risk of hospitalization or death versus 16% in the placebo arm for a 94% reduction. Again, no deaths in the treatment arm and 6 in the placebo arm. And so showing that this agent, oral therapy, is very effective, especially when given early after symptom onset. The biggest issue, as I mentioned, is the pairing of this Normotelravir with ritonavir, which is a very potent inhibitor of the CYP3A enzymes, and there's a lot of drug interactions. And so all clinicians and prescribers should be aware of these drug interactions. The EUA is for individuals that are 12 years and older at high risk for progression to more severe COVID and given within 5 days of symptom onset. When we talk about the drug-drug interactions, the list is fairly large. I treat individuals with HIV, so I'm very comfortable with ritonavir, but even I don't remember all the drug interactions, and I always have to look this up, or I ask my patients what other medications they may be taking for other conditions that they have. But the ritonavir can really elevate the concentrations of many of the agents that our patients are on chronically. And some of these medications can't be stopped or held, such as antiarrhythmics like amiodarone or flecainide, some of the antipsychotic medications, the HMG-CoA reductase inhibitors like lovastatin and simvastatin, some sedative and hypnotic medications, anti-rejection medications. So tacrolimus, I manage a lot of individuals that are transplant recipients, and a lot are on tacrolimus, and there's a lot of issues with the ritonavir and kind of boosting boosting the levels of the tacrolimus. On the flip side, the Malandravir could have its concentration reduced by certain medications. Again, some of these medications our patients may be on chronically, like anticonvulsants such as carbamazepine, or antimicrobacterials like rifampin, and even agents that may not be on their medication list, or we may not be asking our patients about, or they may not be telling us about because they're over-the-counter products, such as herbal products like St. John's wort, which we know can affect the metabolism of different medications. So I think providers really need to be aware of what medications our patients are on, especially when we're prescribing a dual agent like the Malandravir, ritonavir for the mild to moderate COVID-19. The next agent is Remdesivir. So I think most of us are very familiar with Remdesivir in the inpatient setting. We've been using this for starting at about 3 months, if not sooner, into the pandemic. But this agent has recently been approved for the use in the outpatient setting. This comes from the Pine Tree trial. This is a randomized trial of unvaccinated, non-hospitalized individuals with mild to moderate COVID-19. So there's around 560 individuals that had at least one risk factor for severe disease and symptom onset within 7 days. The mean age of these patients was about 50, about 42% were Hispanic, about 62% had diabetes, and about 56% had obesity. This was a 3-day course of IV Remdesivir. The trial was ended early because of some of the changes with different treatments that were, I think, coming to the forefront with SARS-CoV-2, especially the monoclonal antibodies, and changing priorities. But there was some data for Remdesivir in the outpatient setting. When looking at the outcomes of hospitalization or death, there was an 87% reduction in those that received the 3-day course of Remdesivir versus placebo. And for medical visits, so the attended medical visits, which included urgent care ER visits for a COVID-related issue, there was an 81% reduction in the Remdesivir versus placebo. And so this has prompted the FDA to approve Remdesivir for the outpatients, and it's approved in younger individuals. So there was just a recent update to the Remdesivir approval for children at 28 days or older that are 3 kilograms or heavier in weight. So this gives an option for, I think, younger children. And as Paul pointed out with the vaccine, I think that's something that we've been really looking for, our management and preventative strategies for younger children. And so Remdesivir is an agent that can be given to those younger children. Now we look at the monoclonal antibody, the Beptilovum. This is a single intravenous injection like many of the other monoclonal antibodies that we have. The fortunate activity of the Beptilovum is that it's active against the BA.2 variant of Omicron. And the approval for this agent was based off of a phase 2 portion of BLAZE-4, which was pre-Omicron in low and high risk outpatients. And this was a trial that had placebo, Beptilovum, and Bamlanivimab, Etesevimab, and Beptilovum combined. When looking at the hospitalization or death, there was no comparison of this agent to placebo. And when looking at the Beptilovum on its own versus the combination, there was a 4% hospitalization death rate in the combination and a 3% in the Beptilovum alone. Small numbers, hard to make a lot of distinctions between the groups, but it did demonstrate that the Beptilovum was effective as treatment for individuals with mild to moderate SARS-CoV-2. And this then prompted the EUA for high-risk adults over the age of 12 with mild to moderate COVID-19 for whom alternative treatments are not available or appropriate. And then finally, in our list of treatments, we have Malandravir. This received EUA approval in December 2021. This was from the Move Out, our randomized controlled trial of around 1,400 individuals that were outpatients not vaccinated with at least one risk factor for severe disease, with the majority of those having obesity. This was a 5-day course of treatment given within 5 days of symptom onset, with the combined outcome of hospitalization or death. There was a 30% risk reduction when looking at placebo versus Malandravir, so 9.7% for the placebo and 6.8% for the Malandravir. There was 1 death in the treatment group versus 9 in the placebo, so there was a reduction in death in Malandravir versus placebo. Previous data have actually shown that Malandravir can reduce viral load, which may be important in helping truncate the length of symptoms, but also help with preventing spread of infection. There should be some caution and potential fetal harm when using during pregnancy, and so that is something that clinicians should be aware of. And the EUA is for high-risk adults 18 years and older with mild to moderate COVID-19 for whom alternative therapies are not available or appropriate. A couple of add-ons to some of the treatments that we've been looking at over the past 2 years with the treatments we had available. Monoclonal antibodies, so this is going back to Cassivaramab and Divimab, which we are no longer using. But when this was an active component of treatment, one of the big issues was the IV and having to set up centers to infuse this. And so looking at, can we give this by subcutaneous injection? And this data just points towards that subcutaneous injection is comparable to IV administration in terms of the outcome of hospitalization or death, With hospitalization, numerically, there were more hospitalizations in the subcutaneous arm versus the intravenous arm. That kind of just skirted the statistically significant with a p-value of 0.05, but the confidence interval was right at 1. And so clinically, is there a difference in this? And I think this offers potentially easier routes of administration for some of these agents. Also, when thinking about these agents, there are recommendations by the NIH to kind of tier individuals when prioritizing, especially when these agents may be scarce. So here in Illinois, we had a lot of issues with getting the preventative monoclonal antibody Texagevimab, Sogavimab, and we used a lot of this tiering. And so tier 1 were those that were very immune suppressed, whether they were vaccinated or not, or unvaccinated individuals at high risk. Tier 2 were unvaccinated individuals that didn't fit in the tier 1 by age or additional risk factors. Tier 3 were vaccinated individuals at high risk based on age or risk factors in age, or vaccinated individuals that have not been boosted yet, and there was concern that they may not have an appropriate immune response. And then tier 4 were vaccinated individuals that were over 65 or anyone under 65 with clinical factors, and then vaccinated individuals who had not been boosted, again, who were at high risk for severe disease. And so this kind of helped create a path for how we should distribute a scarce resource. Luckily, these resources and agents are becoming more available. I think something else to think about is immune compromising conditions. Paul talked about it. I talked about it with the recommendations. This can be kind of a catch-all from a term that can include almost everyone. But I think we have to look at those individuals that are really at high risk for not responding to the vaccine, or at high risk for that moderate to severe COVID-19. A lot of this group are individuals that have received B-cell depleting therapy like rituximab, and so we know they're going to have a blunted immune response. Those that are receiving medications like Bruton tyrosine kinases or have had CAR T-cell therapy in the recent past. Those who've had stem cell transplants, who have chronic graft-versus-host disease or on immune suppression to prevent graft-versus-host disease, active chemotherapy for hematologic malignancies, lung transplant recipients, other solid organ transplant recipients within 1 year, solid organ transplant recipients being treated for rejection with T-cell or B-cell depleting agents, severe combined immune deficiency, and then individuals with untreated HIV who have T cells less than 50. Those are the ones we should really think of as being very immune compromised or having more severe immune compromised states. I'll end with treatments with convalescent plasma, kind of full circle, in that I think we were talking a lot about this early on in the pandemic, and then we kind of came out of favor, and now it's back again, in particular high titer convalescent plasma. This is based off of a recent study that looked at around 1,100 individuals that were given high titer, so 1 to 320 titer or higher of the convalescent plasma, with the outcome of 28-day hospitalization. And those that were hospitalized, did they require oxygen? And there's around a 54% reduction in hospitalization and just over 50% reduction in needing of oxygen if you were hospitalized. And so this prompted an EUA in December of 2021 for the use of high titer convalescent plasma for individuals who are immune compromised who have SARS-CoV-2. And so a therapy that we weren't using that much, now we're using again. So just to kind of go over, I think, the 4 major therapies that are available for the outpatient setting for SARS-CoV-2. We have Malandravir, ritonavir, a protease inhibitor that's oral, should be taken within 5 days of symptom onset and for 5 days. Really be cognizant of that drug-drug interaction. So know what medications your patient is on, and be mindful of prescribing this based on those interactions. Beptilovum, which is a monoclonal antibody, well tolerated, and this is kind of a second-tier agent for individuals that cannot receive one of the antivirals. There's Remdesivir, which is a 3-day IV infusion, which logistically may make it difficult to administer this agent in the outpatient setting. And then Malandravir, again, another oral agent. There's no drug interactions, which makes this very attractive for individuals who are on medications that interact with the Malandravir, ritonavir. There is a decreased efficacy compared to the other treatments, but again, I think something that we should be utilizing and aware of its niche in treatment. And then a little bit on how to locate these therapies. So, there has been a lot of difficulty accessing or finding where we can send our patients to get these therapies. That DHHS does have this COVID-19 therapeutics locator hub, where you can put in a zip code or your area of practice, and you can see where there's different agents available, such as the Malandravir, ritonavir, which is the Paxlovid, Molnupiravir, the Beptilovum, or the Texagevimab, Silgavimab, which is the Evusheld, which is used as prevention. And so this might help you to access these therapies for your patients. So in summary, we know that there are certain risk factors associated with high risk for severe COVID-19 hospitalization and death, and those include Black, American Indian, Alaska Native, and Latinx. Unequal health risks are the result of different conditions where people live, work, learn, gather, and age, so the social determinants of health. Monoclonal antibodies and antiviral medications are available for outpatients at high risk of severe disease or hospitalization. With current circulating variants of SARS-CoV-2, Beptilovum is the only monoclonal antibody authorized for use in patients with mild to moderate COVID-19. Remdesivir, molnupiravir, and nirmatrelvir ritonavir are available for high-risk outpatients. The Pine Tree trial showed benefit, reduced death, need for hospitalization, medical visit, if used early in outpatients at high risk of progression to severe disease. And nirmatrelvir ritonavir has high potential for drug-drug interactions because of the ritonavir being a strong inhibitor of the CYP3A enzyme.
I didn't know if there were any points that you wanted to go back on that and talk about before we did the post-test.
Sure. Yeah, I think that would be great. And, there were a couple of questions, and Paul and I were discussing this before. And Paul, I think it would be really great to get your perspective at Johns Hopkins with using some of these agents like Beptilovum, the preventative monoclonal antibodies, and Remdesivir. How have you guys figured that out, or have you with administering those?
Yeah, so Michael, I would say there's a lot of variation depending on centers on how this is handled. You pointed out the NIH recommendations. I would say we're using Beptilovum more frequently, especially in our immunosuppressed patients who might have drug interactions preventing the use of Paxlovid, which would definitely be our go-to drug. And that's first tier, and including our state center, which is responsible for infusing monoclonal antibodies. They suggest Paxlovid for those people that are eligible to get drug into them more quickly. The Remdesivir data, I think we believe in. We just, many centers have trouble with logistics, and getting a 3-day serial infusion is just difficult for patients that are infected as opposed to a one-time monoclonal antibody infusion. And even though we don't have much clinical data, I think we generally feel the in vitro data and the mode of action hopefully means that its clinical impact is similar to some of the early monoclonal antibodies. We do have molnupiravir certainly at the after those, but it's right for some patients for sure. And definitely has a cleaner drug side effect profile. So, you do have to individualize it for the patient, but you also have to know the capabilities. But I would say Paxlovid is quite underutilized. So there's a fair amount of education out there, and hopefully the recent Biden administration's program to try to get it into more pharmacies should help make it not so challenging to find where it is.
Yeah, no, and that's great to hear what other centers are doing. And we've experienced the same thing here in Chicago at Northwestern with either the logistic challenges of the Remdesivir. And then I think for me, more importantly, is with the Paxlovid is the drug interactions. We're talking before we went on about, I see a lot of patients who are transplant recipients, and we're both familiar with ritonavir with treating HIV, but that's the long term. I think the effect of these short term bursts of ritonavir, and we've had individuals on tacrolimus that have come back with very high levels of the tacrolimus in their serum, even after telling them to hold the tacrolimus while on the Paxlovid, and even having them hold it the day before we start, and having those increases. And I know you talked about having some of those individuals at your center being hospitalized with the adverse effects from it. And so I think it becomes really important to know about that, but not be afraid to prescribe it, to really, I think, talk to our patients and try to prescribe it when we can.
Yeah, and I'd also say talk to your pharmacist if you're not as familiar with the ritonavir component. Statins, it's not all statins, for example, it's
Mm-hmm.
only some. So pravastatin, for example, is one we've often used for years in HIV care because we know it's not affected as much. Atorvastatin and rosuvastatin or others that are not as affected, certainly by a 5-day course. You may not need to stop. So,
Mm-hmm.
everything sort of depends a little bit, but I think there's rightful hesitancy if people aren't familiar with it. But I think people do have to become comfortable enough so that it's a routine consideration.
Yeah, and I think just like at the beginning of the pandemic, and as we got some of these therapeutics, we weren't all that comfortable with some of them. And we were like, well, should I do this or should I do that? And I think it's a learning curve. And as we all get familiar with these, I think hopefully we'll be able to kind of catch up and be comfortable using these outpatient agents.
Perfect. Well,
All right.
thank you so much, doctors. Didn't mean to put you on the spot there, but I would be remiss if I
No.
didn't get that conversation out to our learners there. As a reminder, as we move into our Q&A, please click that Q&A button to the left of your console. We will try to get to as many as time allows. But to honor everybody's time, if there are some that we don't get to, stay tuned for some of our upcoming webinars and we might just answer them there. So I'm going to start with our first learner question here. Do patients on weekly doses of methotrexate and every 8-week infusions of infliximab for treatment of psoriatic arthritis fall into the category of immunocompromised patients? Dr. Auwaerter, go ahead.
Yeah, well, I'll take a stab at this one. This has come up before, and my sort of view is the TNF inhibitors generally have not predisposed terribly to more severe COVID disease, but more importantly, means that you haven't had much impact on response to immunization. And the same goes for methotrexate, although I think it depends a little bit on the dosing schedule and so on. So, on the other hand, one could argue that it's in your rights to give something like tixagevimab, silagevimab, but in our prioritization scheme, when the drug was a little less available, those patients fell far lower on the tiered schedule. Michael, thoughts on that?
Yeah, I agree with that, Paul. I think our individuals on the TNF inhibitors or agents like methotrexate were in our 3-4 tier. So they were a little bit lower down so we could really focus on the more severely immune compromised. So I would put an individual like this in that kind of mild to moderate immune suppression. And I think a lot of that would probably be the methotrexate, like how high of a dose or if it's more than once weekly.
Wonderful. Dr. Angarone, do the outpatient treatments apply to those at high risk who have been vaccinated and boosted?
Yes. So the treatments are for everyone that is at high risk. And so I don't think we should be moving to the unvaccinated, the vaccinated, or prioritizing in that way. I think we should just look at individuals who are at high risk for severe, complicated COVID that have mild to moderate disease and just give them these treatments. I don't think the vaccination should really play a role in that. Paul, I don't know what your thoughts are with that, but
Yeah, no, I think that's right. What we don't know, and maybe what prompted the question, is really how well, how much of a differential there is in someone that's immunized. You already saw the hospitalization and death rates are far lower, but they're not nil. So I think especially for people at high risk and especially advanced ages, I would be very inclined not to just rely on the vaccine in people with those groups.
Perfect. Thank you so much. I think this will be our final question today as we round this out. This learner asks, what are the restrictions for Paxlovid, only immunocompromised or also those over 65 with a history of cancer or cardiac issues?
and so I think I'll take a stab at this first. I think the Paxlovid is really recommended for anyone who's at high risk for progression to severe disease. And so this would be immune compromised, over 65 with conditions that fit into the high risk category, over 75. I think you could place even those under 65 that have more of those severe immunosuppressive conditions or uncontrolled diabetes or have HIV and they're not under control yet, so they still are viremic, even though their CD4 count may be a little bit higher than the 50. I would include all of those. I would say those that don't fall into those high risk categories as of right now, we're not focusing on that treatment. That may change over time. I think we're really targeting those individuals that we know are more likely to end up in the hospital and end up with a more severe illness.
Okay, well, excellent. Thank you again to both of you for your time and taking time out of your busy practices to be here. For our audience, if you'd like to claim credit, please do click that claim credit button. It will appear when the webcast ends as well. Please be on the lookout for our 30-day survey. You'll get that in your email. As always, please do respond. This will help us develop further education. To our podcast listeners, please rate and review. It only takes a few seconds and really helps us to expand our reach. For those of us joining on YouTube, please be sure to take the post test in the description to claim CME credit. And don't forget to like and subscribe to our channel. You'll never miss another one of our future videos. So thank you, and we'll see you again soon. Dr. Auwaerter, Dr. Angarone, thanks again.
Thanks so much for joining.
Yep. Thank you.